Good afternoon, all of you. Just I want to say that this is the topic which was given was high risk adolescents. Adolescents themselves are highly risky, so it's not something exclusive that high risk adolescents I'm going to talk about. The outline of my presentation is to talk about why to assess. In that, I'll give some introduction to some of the Indian data which is available, and what to assess, and when to assess or when not to assess, and just give a conclusion for it. Why to assess? In India, 20% of our population belongs to the adolescent age group of less than 18. This is according to the Census India. And recently, there are a lot of reports from newspapers and other labor publishers that there is a lot of increase in substance use in the community, and also it is happening more and more at an early age as such. Unfortunately, we don't have much data in the national from the national assessments as such. The general population assessment, the only data which we have is from the National Household Survey, which was conducted by Dr. Ajit and group in 2004. This is a sample of 8,587 individuals, out of which 12 to 18 age group was around 20%. And in them, 3% were using cannabis and 0.1% were using opiate as such. This is only and the NFHS 2006 are the two national prevalence of substance use survey available as such. And along with this national household survey, the rapid assessment survey which was done has found that around 72% of the substance users have initiated their first substance use less than 20 years. This is one report where I will spend some time on this thing. I think there's a delay in this coming. Yeah, this is a study report by the National Commission for Protection of Child Rights and the NIDTC aims. This is purposive sampling of substance using children and adolescents. This is not a general population survey. This is a survey of children using substances. And the best part is it's the first nationwide survey of such sort. This gives the data that for first time we have actually looked at age at which the substance have been started. So we can never say that this was later or this was earlier. All those things we cannot comment at this point of time, because we need to have waves of such studies which will be done over a period of time, which can say that whether the substance use have become earlier these days as such. Except for some of the data from the school-based surveys, we don't have nationwide surveys as such. The few points from the study which I would like to quote was that the onset of substance use was around 1 to 1.5 years earlier among the street children compared to the children who were living at home. So this says that children or disadvantaged children have a higher propensity to have substance use. Second thing is almost half of them experienced physical and psychological problems related to substance use. Again, that gives an idea that why we should assess such physical and psychological problems in this group. And a large proportion of them do have legal issues with respect to substance use as such. This is another alarming thing. Almost around 18 to 29% of them have sex under intoxication, and around 20% of them trade sex for drugs and money. The family factors associated with substance use in these children were this substance use in a family member, single parent or broken families living with relatives or no parents, that does contribute to substance use as such. Fights in the family, issue of physical and verbal abuse, all these family factors do contribute to some extent to the children's substance use problems as such. Majority of them have close contact of friends who use substances, and about half the sample seem seem to have no other external source of pleasures or recreational activities available in their immediate environment. The other data which I would like to add up is our own data. This we have analyzed the screening database of us from 2009 to 2014. We had around 435 adolescents. They constitute around 3% of our population. And there is a doubling of thing happened over a year, still 2014. And we have majority of them falling in the 17 to 19 age group as such. And only as it remains with adults, only 4% were girls. The one thing which I want to show that is that the mean age at onset of first substance use in people in adolescents who are presenting with substance use were 14.5, but the adults were 20.6. So there seems to be a change of substance use, and there is an early onset of substance use. It's an anecdotal evidence as such. Mean age at onset of first substance dependence, it happens very fast in adolescents by 15.5. That is, within a year they do get into dependence, and it takes at least 4 years for the adults as such. This is one thing which I would want to quote. As quoted in the National Rapid Assessment Survey, 64% of our adult did their first substance in their adolescence itself, and 38% of them did have dependence in adolescence itself. Like they have said dependence in adolescence itself, but they reach any form of treatment at a later point of time in their life. And this is into the substances. Nicotine is similar to the adults. Cannabis, solvent, or the difference between adults and adolescents, and alcohol also is less in adolescents when compared to adults as such. So the adolescent drug use profile is different from adults, so we need to look into that in detail. Complications, the DSH attempts are very high in them. So early identification will reduce incidence of complications. Again, these are other complications that even the psychiatric illness also are comparable in this population, but bipolar seems to be a lot more diagnosed in this age group. The family history of addiction, if you like say 70% of the adolescents do have family history of addiction, and they do have a lot of temperamental difficulties, more than twice as such of the adults. So adolescent treatment seekers belong to a high risk category. We try to make an opinion from that. The other thing is that adolescents are highly reluctant to seek any form of treatment also. Whoever comes to this place are reluctant in seeking any form of treatment, so it becomes a challenging task for us to get them engaged in any form of treatment setting as such. Okay, this is about why to assess, and there are some prelude into what all things are needed to be looked into. So what to assess? I would like to divide it into psychopathology and the vulnerability as two parts. In the psychopathology part, I would like to discuss about the substance use history, associated behavioral issues, and psychiatric and medical comorbidity. In the substance use history of use of any drug, which includes licit, illicit, and miscellaneous. I have put in miscellaneous over here because inhalants I couldn't put in anywhere else other than miscellaneous as such. And some of the prescription drugs also could be put in only in miscellaneous. So I consciously put it as history of use because many of them would not have dependence set in by the time when they reach us. So it should be use of the substances also need to be assessed. The second thing would be what is the age at onset of such use? It could be the first thing would be recreational or experimental use, which starts with, and then it moves on to a regular usage like once in a month according to the WHO's definition, and then it moves into dependent usage, which is defined as per ICD-10 or DSM-5 criteria as OSEF today. It is good to note the age at onset of each of these things, like when is the recreational use started and when they have progressed on to dependent use as such. Mode of use, the route of use in how they are using it, it needs to be assessed, because that's going to tell about the complications which they might be ending up with, or some form of treatment also may change with the mode of use as such. Right? Course of use, how frequent they are using, how long they are using, what is the pattern of usage, whether it's recreational use, regular use, or dependent use. Based on that, we will decide what kind of management strategy has to be adopted, and how the functionality of the adolescent is affected because of the substance use in the course of the substance use as such need to be assessed and documented. Factors responsible for the initiation of the substance, maintenance of substance, and lapses and relapses. This is the most important part, because this is going to help us in making any treatment plan, both pharmacologically and psychologically. And what is their motivation to change? Motivation to change need to be assessed for each substances which are there, because they may not be willing to stop tobacco, but they may be willing to stop inhalants. Putting it that, like, since they don't want to quit tobacco, they cannot put us, they are in denial and they don't want to quit, is not right, because we would like to look at each substance separately and address that separately. If even one substance coming down also is very good. So each motivation to change with respect to each substance need to be assessed. And the factors which needs immediate interventions need to be taken note of, because that's what we will be addressing first. The medical comorbidity which need to be assessed are like, what are the previous illnesses which they've had, if they are injecting drug users, looking for ulcers and abscesses in the physical examination, gastrointestinal and genitourinary symptoms, chronic fatigue, recurrent fever, weight loss, nutritional status, recurrent nosebleeds, infectious disease. Pregnancies also need to be looked at. This is something which we don't usually ask in our adolescent women, but it's very common and which needs to be assessed. Comorbid psychiatric illness, axis 1 disorders, especially depression and anxiety, are something which are very common in this age group, so that needs to be assessed systematically. And suicidal behaviors, which we had seen in our population also, is very high, need to be assessed. Both the deliberate self-harm attempts and the death wishes, suicidal ideations need to be systematically assessed and documented. The other developmental issues or developmental disorders in the form of attention deficit hyperactive disorders, learning problems in the form of SLDs need to be assessed, which can contribute to some of the problems in the schools, and that results in negative emotion and resulting in substance use also. And influence of some of the traumatic events, both physical, emotional, and sexual traumas, can influence the person's attitude towards substance use also. Sexual history, looking at sexual orientation, it's optional unless it is a problem for the person, or that contributes to the substance use. There's no point in going into details of it, like it's optional. Sexual activity per se, sexual abuse history, if it is present, the highest sexual behaviors in the form of someone who is trying to have sex under intoxication or trading sex for the drugs and money, these needs to be assessed. And unprotected intercourses are need to be assessed, and this need to be documented, and this need to be explained to the patients for in the education part of it, which will be happening in the management. Sexually transmitted diseases need to be checked, and sexual dysfunctions in case if it is present. Many times the anxious adolescents do have issues with related to masturbatory anxiety and that syndrome kind of things do come with sexual dysfunctions as such. School or college history, what is the academic and behavioral performance, attendance problems, what is the relationship with their peer group. We know that a lot of the peer group do use substances, so what is the nature of the contribution from the peer group to the adolescents' drug use behaviors. What is the interpersonal? How is the interpersonal skill? Whether they are able to handle their peer group well, they are able to say yes or no to what they want or what they don't want to do, and is there any gang involvement or doing criminal things in groups as such need to be assessed. It also holds good for the neighborhood environment, because many a times there will be school dropouts. We may not be asking for the school environment, but even the neighborhood environment, parents will come and tell that they are mingling with adults around in the neighborhood, and they are not a part of their school community as such, but they contribute to most of the problem behaviors as such. Occupational history, if they are employed, many do are employed in our data, which said almost around 50% of them are school dropouts. They have some form of employment, whether regular or irregular employments. Like regularity and consistency of work, how is the workplace behavior, how is their interpersonal communications in the workplace, and how they are doing money management. All these things will be affected with substance use related problem as such. Like, so this needs to be assessed and documented, so that this had to be helped at a later point of time for successful management of substance use disorders. Complications and consequences, this will include a host of issues in different domains like physical health, mental health, legal issues in the form of drunken driving and petty thefts, drug peddling, etc., etc. Social issues, like family issues, family discord, vocational problems. All these things need to be assessed and documented. Some of these kids are at greater risk than others. This slide, which many of you might have come across, this is a vulnerabilities to alcohol dependence slide as such, like where people who have family history of addiction, have externalizing spectrum disorders, antisocial personality, conduct disorder, ADHD, do have higher vulnerability to get into these kind of substance dependence. Access form disorders in the form of bipolar disorder, anxiety disorder, schizophrenia do have higher propensity to get into substance use disorders. Toxic stress in the form of poverty, violence, poor parenting, nutritional deficits in childhood also contribute to it as such. Looking at in little more detail, family history, temperament, and environmental factors. In the assessment, a 3-generation genogram will help in making this family history documenting done. Both family history of addiction and family history of mental illness both need to be asked and documented. Like, this is because we know that 40 to 60% of vulnerability is attributable to genetic factors too. Also, it includes the parents, not only the parents, guardians, and the extended family's history of chronic illness, substance use disorder, mental illness, incarceration or illegal activity in them, different other child management concerns, homelessness, home environment also need to be assessed with respect to this, and the family strengths and weaknesses, which would come up at a later point of time, need to be noted. With respect to environmental factors, loss of parental diverse and conflict, isolation and abandonment, single parent family, loss of child, unfaithful significant others, loss of home to natural disorder, death of significant other or close family members, victims of violence, physical neglect, physical, emotional, sexual abuse. This is not specific to adolescents alone. It's even common with adults also. But adolescents, being a growing brain, are more vulnerable to the HP axis from overactiveness as such. Like nutritional deficits, toxic exposures, peer deviancy, exposure to illicit and illicit drugs are all contributing to the environmental factors, and these needs to be systematically assessed. Temperament, there are two different temperaments we tend to assess as such, like externalizing and internalizing temperaments. Externalizing in the form of high risk-taking behaviors, emotional dysregulation, impulsivity, inattention, conduct symptoms, oppositional disorder symptoms like lying, stealing, and other conduct symptoms as such. Like internalizing symptoms in the form of low self-esteem, low mood, anxiety, poor communication skills, poor coping skills, passivity and passive-aggressive way of communications, procrastination and avoidance behaviors as such. Like these two different temperaments, both are vulnerable for substance use per se. Most of the times, they both are present together. It is not mutually exclusive groups. They do have both the abnormalities together. This is an additional side assessment for behavioral addiction, because there are many kids who come with different kinds of behavioral addiction issues in the form of gaming or social network site usage, or the cyber pornographic issues as such. Like it's instead of calling it as addiction per se, look at the behavior, describe the behavior, pattern of the behavior needs to be mentioned. Why do we consider pathological the behavior as pathological, and what does this behavior what's the purpose this behavior serves for this particular boy or girl, adolescent's perspective of the problem itself, how other dimensions of life are affected due to this behavior. These needs to be assessed, and this will be helping us to decide how are we going to manage, whether many of these disorders haven't seen the light of the day in any of the classificatory system, but these kind of problems do come to us on the clinic on a regular basis. So these issues had to be assessed, and this will be used in the management purpose. Structured clinical assessment, there are many which are being used. Like we don't use it on a regular basis. Like some of the assessments which may be of use is Teen Addiction Severity Index, which is again as an open source thing, and Minikid, which is not open source document as such. Like temperamental measures in the form of, these are the measures which we commonly use in the clinic over here. The BISBAS scale, which is behavioral inhibition and behavioral activation sensitivity scale, which is also available in the open source, which looks at both the internalizing and externalizing temperament together. PSRS scale, which is basically the adult ADHD rating scale. Strengths and difficulty questionnaire again looks at the temperament part. The adverse childhood experiences scale, which looks at the various kind environmental and adverse childhood experiences which any child can go through. This can be assessed through this scale. It's a fairly simple and easily usable scale as such. Withdrawal assessment scale, these are the most commonly used scales in case of dependence as such. Like, and this is it's not different from many of the adult assessments as such. Like, and the specific scales for the comorbid disorders, which include social anxiety or depression or the suicidal behaviors, can be used for this also. Objective drug screening, I think the last week Dr. Lekansha discussed in detail about this part of the presentation. Urine drug screening kits, quantitative estimation of drug levels, and ethyl gluconate, CDT, GGT for alcohol use as such can be used. Okay, there are three scenarios which I would like to push in. We need to, I'll also, because for want of time, I myself will think about what needs to be done in the three scenarios as such. Mr. X, a 16-year-old boy, brought by parents, complaints of bunking by teachers, doing poorly in school. Parents say that they suspect he might be drinking and smoking, as they found empty cigarette packs and lighter in his clothes and seems dull and drowsy at times. He has been told he was going to visit a relative today, but has been brought to OPD. Many of us face such kind of patients on the clinic every day. Mr. X urine tests positive for cannabis. He is very reluctant to see you and troops into the OPD, avoiding eye contact. Here, the assessment need not be very detailed. We need to be kept as simple as possible. Just talk to the adolescent first, assure confidentiality, non-judgmental attitude, active listening, establishing a mutual trust. Keep the assessment as minimal as possible. Just 3 to 4 questions about whether they use it or not, whether their use is regular or not. Not even going into the dependence part of it as such. Is there anything which they need as a help with respect to substance use? These are the few questions which we usually use in the screening when they come for the first time. Try to identify a common treatment goal in the form of studies or concentration in some of their study related issues, or handling the parents and their and the way in which they handle the adolescent as such. Likewise, just identify a common treatment goal between the adolescent and the treating physician. Engaging the family, they need not be handled together, they had to be handled separately, and try to sustain the engagement with the adolescent and arrange for follow-up. Seen 2 weeks later, Mr. X's parents comes in a panic. He's got into fight with his friends while under the influence of cannabis and alcohol, as reported by his parents, and was taken to the police station. Now, no charge was eventually filed. He doesn't remember the exact events of that day. Mr. X's parents insist on admission. Your approach would be to, again, this is also a very common scenario which we come across. Like, this is a crisis with which the boy had come in. Again, we cannot go into the details of various drugs used and the family history and all those things at this point of time. What is there is this a crisis. You need to do some amount of debriefing and ventilation about all the concerns. The boy may be willing to talk about certain of these issues because that is a teachable moment. Take that opportunity. Use as less assessment points as possible, like about the substance use as such, and discuss with the boy about the different options. And one thing what I would like to do at that point of time is to create an opportunity for him to come back again rather than trying to push everything at that time itself, because he will not be in a position to talk to you also. Since Mr. X has been doing better, he still uses cannabis occasionally, but has been taking medication to control urge and craving. However, he is still not doing very well at school. He leaves projects half finished, cramps for exams at the last minute, and has difficulties during his practical exams as he becomes so nervous when someone's observing him that his hands shake and he forgets the sequence of steps he must take. He says this troubles him more than the difficulties he's had with the police. Here, the rapport would have been better if you have handled it better in the previous two sting. Like here, you can aim at doing a detailed assessment of the substance use disorder, and also the vulnerability components can be assessed in a more detailed fashion. And the actual focuses and the tangible outcomes can be decided in this visit and the assessment itself. Like to conclude, systematic assessment of the drug use and related behavior along with the vulnerability would give better insights for the management. Modify the goals of assessment with respect to the individual's need, their motivation, and the situation in hand as such. Thank you.